Okay, what is the topic for today? And this is very important. I think this is a very important. I cannot emphasize that. I cannot overemphasize it. That this idea or this information is something that everybody should know. Obviously, I'm going to discuss about COVID again and the effect of the infection and the injection. So, what I'm going to present to you, and you will see it in the slide, is I'd like to compare the um, uh, the AIDS, um, acquired immune deficiency syndrome that is happening in both COVID and HIV. Everybody is very familiar with HIV, and it's been around. If not exactly the same, it is very similar. So, SPAIDS, SP means spike protein because that is the common denominator of an infection and of the injection, COVID infection, COVID injection. What's causing the disease is actually the spike protein. So, to cover both injection and infection, we will call it SPAIDS versus HIV AIDS. So as you can see, um, I have these are several feature. I'm just looking at the slide because I cannot see it being projected. So what's causing HIV/AIDS? So obviously it's the HIV, the human immune deficiency virus. Whereas in SPAID, you have several, well, the COVID itself, the mRNA vaccine, which produces the spike protein. And then the other feature of the um, COVID injection is there are other elements in that injection that can also cause a lot of inflammation. I decided to put the lipid nanoparticle. So, and obviously, it's already known that the injection is also very much contaminated by plasmid, DNA plasmid, the SB40. And so it can cause some genetic modification in our own genome once you have the injection inside our body. So the other one, what are the other feature? The CD3. The CD3 is, remember, what's getting deficient in these two disease syndromes, what's getting deficient is actually the T lymphocyte. And there are three types of T lymphocyte, or even, yes, three types. The major types of lymphocyte that we have to look at is the CD3, which is the total population of adult lymphocyte. And then we go into a CD4 and CD8. The CD4 is the lymphocyte, the T lymphocyte, the immune cell that is becoming deficient in HIV. Okay? And CD8. And then we go into a CD4 and CD8. The CD4 is the lymphocyte, the T lymphocyte, the immune cell that is becoming deficient in HIV. Okay? And CD8. And then we go into a CD4 and CD8. The CD4 is the lymphocyte, the T lymphocyte, the immune cell that is becoming deficient in HIV. Okay? And CD8. And then we go into a CD4 and CD8. The CD4 is the lymphocyte, the T lymphocyte, the immune cell that is becoming deficient in HIV. Okay? And is the one becoming deficient in COVID. So going back to the CD4, look at this. In HIV, the CD3 is actually unaffected. So the total population of the T lymphocyte is still relatively intact or relatively good. Whereas in the SPAIDS or the COVID AIDS, the is the one becoming deficient in COVID. So going back to the CD4, CD3 significantly declined. So it's the total population of the immune cell, of the T cell. Going down, the CD4, this CD4 is severely affected in HIV. So you become immune deficient because the CD4 is going down. If you remember, you guys can go back. You can read that in the past there were actually cancer or injection rollout, and I have not seen anybody who actually recovered. It's not recovering for whatever reason. I think it's continuing to die. It is a very sad thing to say, but you have to doubt what I say because, as I said, this is my clinical observation. Okay, so side in HIV is generally not affected. It is not affected, whereas in SPAIDS or COVID, it is affected. It goes down. So you can see that now that there are two major things affected in our immune system when you're talking about the COVID. So you have the cell mediated immunity, which is a deficiency of the CD3, CD8, or your natural antibodies. The subclasses or the antibodies, IgG, subclasses 1, 2, 3, 4. Subclass 1, 2, 3, 4. Okay, and they have different function. Now, with the IgG in COVID, again, from my clinical observation, it's almost like a signature. The IgG subclass 1, IgG subclass 2 are mainly affected. In the HIV, none. So, and there's also a very peculiar feature that is happening. The IgG subclass 4 is switching, meaning it's increasing. And what's the significance of that? The IgG subclass 4 that is switching or going up is actually a risk factor for developing cancer. The IgG subclass 4 is supposed to help us combat or alleviate our allergies because the IgG subclass 4 is the one telling your immune system do not react to pollen because it's not an enemy. It's just something that comes in and it's not going to do anything to the body or to the system. But what's happening because you have so much spike protein that are being produced because of the vaccine, or I should say, because of the injection, then the immune system somehow is perceiving the spike protein like an allergen. So, if that is the case, it's an allergen, but it's actually a carcinogen. You see that? There's a big difference are happening now, not only in the older population. Usually cancer is happening in older population because that's another degenerative disease. No, it's a disease of the older population. However, everybody should notice this now that there are the rate of cancer in young people, and we are talking about young people. Where do you see pancreatic cancer on a 13 years old, on a 12-year-old? Like in women, there's so many colorectal cancer in women below 40. I have a couple of cases on that, but obviously it should not be happening um, in these young people. No, I have a few colorectal cancer actually that I'm treating right now. And so the pancreatic cancer is amazing. Since last year, mid of last year, I actually have at least 7 cases of cancer are happening now, not only in the older population. Usually cancer is happening in older population because that's another new of pancreatic cancer, and they are all far advanced. This is what we call, I know the public is calling this turbo cancer. There is no turbo cancer, there's no terminology, or we don't have a code for that, but the public, common people, are labeling it as a turbo cancer because of its size and um, the severity is far advanced. It metastasized already all over. You know, stage 4 is a metastatic disease. They come um, big in sizes and widely metastasized. And so, turbo cancer, once the patient is diagnosed, literally, they're gone in 3 to 4 months. But now it's changing because we have some realization that we really have to take care of the spike protein, which is the disease causing entity of this whole thing, or it is the driving force. So we need to address the presence of the spike protein in both the injected and so what else? The other feature is, as you can see, is the reactivation of the latent infection. And latent infection. And what are the latent infection? The most common ones are the herpes viruses. Um, in AIDS of HIV, there are some herpes viruses that are also reactivated, and again, the most common is Epstein-Barr, but the herpes simplex are also getting reactivated. The CMV, the cytomegalovirus in HIV, when it goes to the eye, to the eyes, it can cause CMV retinitis, and at one point, it's one of the most common cause of blindness in HIV. Okay, in AIDS patient. What about the COVID? The tragedy is it's so much more. Again, the Epstein Barr is the most common. Okay, let me put it this way. The CMV was actually more common in HIV, at least at that time, activation. And that is what's happening here. The reactivation of this virus is incredible, is horrendous. And this is what I am seeing again as a clinical observation. Epstein-Barr virus is number one reactivated. The other ones are like the herpes simplex 1 and 2. The herpes simplex 1 is more common, and it's very bad. It's very bad in the older population because it can affect their memory. I mean, the spike protein is already causing a lot of cognition issue, cognitive decline, and memory issue. Then here you are with the herpes simplex type 1. So I have the CMV, the cytomegalovirus, just like the HIV, um, is also reactivated very commonly. And then there's another one, which is the human herpes virus 6. And that is very notorious for causing autoimmune. But all of these viruses, including the Epstein-Barr, can actually precipitate or aggravate the autoimmune um, uh, disorder or process. So what else? So that's the difference between the two in terms of um, virus, latent viruses reactivation. And on top of that, since it's the CD8 deficiency, it can also reactivate Lyme, it can reactivate TB, it can reactivate syphilis, it can reactivate um, uh, MAC, the atypical mycobacterial disease, and I'm seeing that whatever cases I have, it can also reactivate sarcoidosis in the lung. It can anything that is dependent on CD8 T lymphocyte to be under control. They are coming out, and the diseases are happening. Okay. So, what else? This is one thing that I'd like to emphasize also, the development period. How long does it take for the HIV to cause AIDS? AIDS. Let's say it doesn't have any treatment. You don't treat the HIV infection. How long is it gonna take for somebody infected with HIV without treatment? How long is it? How long would it take to develop for the AIDS to develop? Um, the range is between 8 to 15 years. You see, that takes a long time. But now that we also have treatment for the HIV, it's even longer, or sometimes it doesn't even develop because you control the HIV, the virus itself. What about COVID? I'm telling you now, it's on the sixth year, and I already see this so commonly. So it takes one, even on the first year that I started testing these people, and that was in 2021. The rollout was when? December of 2020, the rollout of the vaccine, but everybody was getting infected. So by 2021, that I started testing or actually working this patient up and to find out what is going on and to obviously help them. I need to know what I'm dealing with, because when the patients come to me, they have multiple, symptomatology, and so I have to do the blood test to find out exactly what uh, is going on in terms of their immune system, in terms of their endocrine system, in terms of hematological changes. And that's how I came up with this comparison. And it takes between 1 to 5 years. And this is happening to everyone. It doesn't matter um, whether it's a 10-year-old, 13-year-old, all the way to 100 years old. It's happening. And I would like to emphasize also, and I was not able to put this here, is the presence of autoimmune disease or disorder. It's happening in HIV, you know, it's, what do you call it? It can happen, but it is variable. Can happen sometimes, it doesn't happen at all. But in COVID, in spades, I'm tempted to say that's 100% of people who got infected and injected are actually developing the autoimmune disease. And I will discuss that separately. Actually, I have an upcoming lecture in one of the big recreational center here in the villages, and the title is the lecture is about autoimmune diseases or disorder after the pandemic. Yeah, I hope you can attend, whoever is listening here in America. It's going to be a very interesting lecture. I'll explain to you, what causing it, how it's happening, or what we call pathophysiology or mechanism of disease, and then um, what are the different types of immune diseases that I see and what we do to treat it. Okay. So, what else? I think those are the, you have to go back to this comparison so that you know. And because of this, I encourage everybody to be tested. I have also an upcoming, I think, lecture with doctors. There are a group of doctors. They are an hour or 2 hours away from where I practice, but um, I'll see if I can go there and actually um, discuss whatever is happening and kind of train them, um, or share with them how I treat these cases because it's horrendous. I think this is another pandemic after that acute pandemic. This is what is happening. Anytime that you talk about infection or injection, there is something that is happening inside your body, irrespective of your symptoms. That means it's asymptomatic, but there are things still happening. And that's why I encourage the doctors, to look into this, and doesn't have to be me who should teach you, but we're all doctors. We have the background, and you can actually figure out what's happening. But for those people who will be joining me in those discussion or meetings that we're going to have, upcoming meetings, then I will tell you all the things that I know and everything that I have observed. Okay, so that's the comparison of AIDS, HIV, AIDS, and the SPAIDS or the COVID AIDS. And I hope you learned something. And please go back to it or go back to what I'm saying. Sometimes there's a little bit of confusion, and so if there are some what do you call this? Inconsistency, well, ask me down there here in the comments, and then we'll clarify it. Okay. All right. That's HIV AIDS versus SPAIDS, COVID AIDS. Okay. Thank you so much for listening. This is Dr. Vila again.